Hi, welcome to Billing in BC, the basic module. I'm Eric Kudesky. I'm a clinical assistant professor in the Department of Family Medicine at the University of British Columbia, and I'm delighted to be with you today to learn about one of the most important things that you can, billing. So, there is a disclosure side, and I have absolutely nothing to declare. There is some mitigation of bias, and my job is to try and present the facts and tell you about my experience and pass on some of the expert advice from the General Practice Services Committee that I've learned along the way of my more than a decade in clinical practice. The learning objectives today are to describe the basics of office fee-for-service billing, to talk about some of the most common billing areas that family physicians miss. Now, we're not going to talk specifically about the GPSC billings. That's what the advanced billing module is for. So today we're going to go over the basics, the day in, day out, and then the fancy stuff we'll save for the next talk, which I hope you'll join me for as well. A disclaimer that the Medical Protection Act requires that every physician maintain records. What this means is that if you bill for something, you better darn well make sure that you have documented it. Because if it's not in the record, it did not happen. So very, very important to do that. And what I'm going to say today is that practices change, rules change. My job is to tell you the best of what we know now, to tell you the best that I've learned from the experts, but certainly don't take it from any one person. If you have any questions, you can always contact the Medical Services Plan. You can always contact the Society and section of General Practice. And certainly don't just rely on your colleagues. And so when you bill for something, you are saying that this is what indeed happened and you're billing the right code. So make sure that you're doing it, because it may be years later if you make a mistake that it's caught. And if that's the case, it will all be clawed back and then some. So very, very important that whenever you have a question, you ask the right people, the Ministry of Health and Medical Services Plan or the section of General Practice, and that you document. Because if there is a dispute, you can't just say this is what you did. Your notes have to speak for you. In terms of billing systems, there are plenty. To paraphrase Winston Churchill, fee-for-service is the worst form of billing except for all the others. So fee-for-service is how the majority of us doctors are paid. Some of you may get some sessional payment, currently over about $130 per hour. So those of you who are doing work perhaps on the downtown east side or in one of the specialized clinics. Most family doctors are not salaried. There are some exceptions, and you can think about places like the cancer agency where you'd want someone to be salaried. There are capitation blended models. Again, those are mostly ones that have been grandfathered in, and there are a few sites still in the province that do that. There's what's called APP, the Alternative Payments Program. Many of the hospitalists are paid this way. And then there are also bonuses and incentives. You'll often hear MOCAP, the Medical On-Call Availability Program, for people who are carrying a pager or who are on call in certain areas. There are rural retention, rural premiums, and the whole idea is to incentivize the proper behavior, and perhaps we can incentivize the behavior to put a U in there for the Canadian spelling, but every billing system you can think of does have loopholes. Every billing system you can think of isn't perfect. And so fee-for-service is how the majority of us are paid, so we better learn it. Now, even though there is an ICD-10 at the timing of this recording, we still do use the ICD-9 codes, and that usually goes by body system. And sometimes you want to be specific, and sometimes you want to be vague. Most of the time you do want to be specific, and when we talk about the GPSC incentives, that's one of the few examples and the few times when you do want to be vague. But for the most part, instead of just putting head and neck, you want to put something down like continuous migraine without aura. Again, the better the billing, the easier it is for people to code what you've done, and the better it is to show that you've done your proper due diligence in putting down a diagnosis. So certainly, whether you're audited, when you have your profile, the more specific your diagnoses are, the better it's going to be. And there is a link here to some of the codes. Billing, of course, matters because fee-for-service is the predominant method by which family physicians are paid. And it's really becoming increasingly complex. But it behooves you, and it literally pays you to keep on top of it, because if you miss your billings, that's a loss of income. And certainly, if you're thinking about practice management skills, hiring and firing is important, negotiating a good rate with BC Hydro, but billing is where a lot of doctors leave a lot of money on the table. And when we think about all the costs that we have to live in this beautiful province, getting paid for the work that we do is very important to allow us to provide the best care for our patients, to run our offices, and to enjoy all the beautiful BC has to offer. Let's talk about visit codes. So when we're billing for visits, it's a mathematical formula. There's a prefix and a suffix. The prefix is based on age. If someone is between the ages of 2 and 49, it's a 001. If they're between the ages of 0 and 1 year and 364 days, then it's a 121. So 0 until the second birthday is a 121. From your second birthday to the day before your 59th birthday is a 001. From your 50th birthday to the day before your 60th birthday is a 153. And then so on. 60, 69 is 161. 70, 79 is 171. 80 and up is 181. So a couple of things to notice. First of all is we go 121, 153, 161, 171, 181. So you may ask, why is it that we don't have 151? Wouldn't that make sense? And the answer is it would, but the 153 was added on afterwards because the 001 used to be from the ages of 2 to 59. And the government recognized that people in their 50s were requiring more care and more specialized care and more complex care. So they put in an extra fee for people who were in that 50 to 59 age group. Unfortunately, at the time that got put in, the 15020, 15030, and some of the other 151 codes were already in existence, and we'll talk about that when we get to talking about urine and some other exciting billings. And so 151 was already taken, so 153 is the series. Also, even though people are living into their 90s and 100s and above, the code stopped at 181. So the first three numbers are always going to be based on age. The suffixes, the last two numbers, will be based on what you do. If it is a routine visit, it will be 00. If it's a counseling visit, the last two numbers will be 20. And if it's a complete physical that you've done the time for and that is warranted, you will bill the code with the last two digits being 01. So you can see we're doing 5 digits. First three are based on age. The last two are based on what you actually did. Now, to add a little bit of complexity, the location where you do it matters as well. And so if you are out of the office, that third digit will be a 2. So just like a mathematical formula, you'll put in the age, you'll put in what you did, and that will give you a 5-digit code. And then if you did something out of the office, that middle digit, the third digit, will become a 2. The exception is for the out of office for ages 2 to 49, and that will be a 13200. But if you have difficulty remembering that, just look at this chart. So we can imagine here, if we take the first one, an in-office visit for someone up till their second birthday. Up to the second birthday, the prefix is 121. The office visit, the suffix is 00, so the code will be 12100. Let's say we take someone in their 50s with an in-office complete physical. Well, they're in their 50s, so the first three digits are 153. And they're getting a physical for the last two digits are 01. So we put that together, 15301. And let's think about someone that we're doing counseling out of office. So, and let's say this person is 75. So we go through our steps. The prefix is based on age. They're 75, so it's 171. We're doing counseling, so the last two digits are 20. So we're left with 17120. But because we're doing it out of the office, that third digit flips to a 2, so we're left with 17220. Now, a couple of caveats about the complete exam. That even though patients say, oh, it's time for my annual or my routine physical, that may exist for cars, but it doesn't exist for British Columbians. The Medical Services Plan does not pay for routine physicals for healthy patients, so there's no such thing as a checkup, and as you know, this is not supported by evidence. You can have periodic health exams, but again, those are generally shorter visits, and they're not the same as a complete exam. A complete exam is where there is an indication to do that. Now, if someone needs it, maybe there's a new cancer diagnosis, maybe there's a new worrisome symptom, and you really do need to go over and do a complete exam, you can bill it up to every 6 months. But certainly be sure to write that reason in and say, Complete exam done 7 months ago, but new unexplained weight loss with night sweats. Certainly, as part of a complete exam, you want to be, well, complete. So you want to have your SOAP note. You want to have the family history. You want to have your review of systems. So make sure you have the subjective, the objective, your assessment, and your plan, so that if someone does go back and take a look and say, why is it that we're going to pay you for doing complete physical, that you have all of this information down. Now, a PAP, if it's not indicated, does not need to be done in a complete exam. So, for example, in British Columbia now, the evidence is that we start PAPs at 25, and we do them every 3 years unless there's another indication, such as abnormal results or high risk. So if someone has had a PAP in the previous year or 2 years, and there's a reason that they're getting a complete physical, a PAP does not need to be done. Also, if someone is having their period, the PAP does not need to be done that day. They can come back for that another day. And if you're seeing a newborn or an infant, you cannot bill a complete physical when they're 28 days old. That's also usually around when they get their MSP. So the first few weeks or months of their lives, infants are billed under their mother's MSP number. And then once they get their own MSP number, then you can bill a physical. Now, I know you're going to say, every time I see a newborn, every time I see a 2-month-old, a 4-month-old, a 6-month-old, a 9-month-old, a year-old, an 18-month-old, I'm doing enough that would be a full physical. And I agree with you. You're doing everything. You are being very thorough, asking about development of full physical exam. You just don't get paid for that full thoroughness except every 6 months. And if you're in doubt, you can call MSP or you can bill for a physical, and make sure that in the billing screen of your EMR that you put in the explanation for why it is that you needed to do a full physical if you feel it doesn't fit in with these general rules.